Hello, and welcome to ID Talk, answers from infectious disease experts. I am Dr. Scott Olson, a pediatric infectious diseases specialist at Banner University Medical Center in Tucson, and associate professor of pediatrics at the University of Arizona College of Medicine. Along with Dr. Nathan Price, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. And if you're looking at the thumbnail of the podcast, Dr. Price is the handsome young man on the right, and I am the one on the left. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunizations related. Thanks for tuning in today. This is the week of April 7th, 2025. And before we get into the questions, I have to admit that I have been busy preparing an upcoming talk I have on meningococcal vaccines for the 2025 Arizona Immunization Conference, coming up April 15th through the 16th in Mesa. So I haven't had as much time to do deep dives into all these questions, but as always, if there are follow-ups after we're finished, please feel free to reach out and I will try to address those in future episodes. For the time being, let's go ahead and jump right into the questions. The first question from a member asks, should frontline healthcare staff receive titer testing to ensure that they are up to date on their MMR vaccine? Should pediatricians be recommending titer testing for parents or patients? And this is obviously a question on everyone's mind right now as we're dealing with the growing outbreak of measles in 3 states, including Texas, New Mexico, and Oklahoma, with currently over 500 known cases. And unfortunately, over the weekend, we learned there was a second pediatric death that occurred in Texas in an unimmunized child. Thankfully, we have not seen any cases in Arizona at this point, but I think it's a great time to review immunization recommendations. For context, I think it's good to remember that vaccine effectiveness after a single dose reaches around 93% effective at preventing measles if you were exposed to a case. And we routinely recommend a second dose because we know that we increase the efficacy from 93% to about 97%. So we know that as long as someone has had 2 documented doses of the MMR vaccine, most individuals are very well protected. And unless they're in a high-risk scenario, most individuals don't recommend that you check titers in individuals with those 2 doses. Now, if we look at the history of vaccination against measles, the first vaccines were administered in 1957. And because the virus is so infectious, it's presumed that most individuals born before that point who did not receive immunization are immune due to natural infection. For individuals born after 1957, if there's either no documentation or immunization or infection, then recommendations are you can either give a single dose of MMR or check titers to see if the individual is already immune. Additionally, in the period up until 1967, the first measles vaccine was actually an inactivated or killed virus vaccine, and we've learned since that time that individuals immunized with this vaccine may not have experienced lifelong immunity. So if they were immunized during that window, or they know for sure that they received the inactivated vaccine, then the recommendation is you can also either provide a single dose of MMR or check titers. For all others born after 1967, as I mentioned previously, as long as they have a documented 2 doses of MMR, then titers are not recommended because they have a greater than 97% likelihood of immunity based on those immunizations. Now, for healthcare workers who have a higher likelihood of exposure to measles, there is a slightly different set of recommendations. And in that context, the CDC recommends that all healthcare providers should have evidence of presumptive immunity. Now, what that means is individuals should have either written documentation of vaccination with 2 doses of measles-containing vaccine, or laboratory evidence of immunity, which means a measles IgG in the serum, or laboratory confirmation of prior disease, or birth before 1957, as outlined previously. And while these recommendations are laid out more concretely for healthcare providers, some individuals also recommend that other patients or individuals who are at higher risk for either acquisition of measles or severe outcome if acquiring measles should also have titers checked without documentation of 2 measles vaccines. And these groups that are considered at higher risk include pregnant people or those planning to become pregnant, students in post-secondary educational institutions, international travelers, and solid organ transplant candidates and recipients. And the last thing I'd like to say on this topic is that remember, these recommendations were developed by the CDC during the era where measles had been eradicated from the United States as an endemic infection. Now, we're still not at the point where anyone would consider measles endemic in the United States anymore, but I think as we're seeing the growing number of cases in the current outbreaks and unfortunately seeing the declining rates of vaccination in the community, we may be entering an era where we have to be more vigilant and careful with measles, and so these recommendations could change potentially in the next several years, so more to come. All right, moving on to question 2. One member wrote in, for patients with a mild case of pneumonia, what is your typical treatment plan, and when would you prescribe a nebulizer? Well, in general, I tend to recommend the same treatments that are outlined in the Infectious Disease Society of America, or IDSA, Community-Acquired Pneumonia Guidelines for Pediatric Patients. First thing to point out there is to remember that in infants and young children, viruses are still the leading cause of pneumonia or lower respiratory tract disease. And so, particularly if you see someone who has diffuse crackles or diffuse lung involvement, and they're within that age group, you really want to ask yourself, how convinced are you that this is something that requires antibiotic therapy, particularly because I think we all know that we tend to overuse antibiotics in the pediatric population. If you're convinced that this is a bacterial pneumonia, I tend to recommend that first-line treatment for younger children is amoxicillin, which we know still retains good activity against Streptococcus pneumoniae and other bacteria that can cause pneumonia in children. Now, the member asks specifically about mild cases, so I would assume we're not talking about inpatient medicine, but remember that for those patients who are admitted, ampicillin is a wonderful first choice of therapy for most routine community-acquired pneumonias in children. If there is a significant allergy against penicillin or amoxicillin, then as long as it's not anaphylactic, most children could be treated with second or third generation cephalosporins because there doesn't tend to be a lot of cross-reactivity when it comes to allergies. If there is a concern for severe allergy, then you could always use a respiratory fluoroquinolone, such as levofloxacin, which still retains good activity against Streptococcus pneumoniae. In older school-age children, we start to see a rise in more atypical pathogens, such as Mycoplasma pneumoniae. And for treatment of these infections, macrolides such as azithromycin are considered first-line treatment, with alternative options being respiratory fluoroquinolones or doxycycline. And one quick reminder, even though we don't normally think of the atypical pathogens such as Mycoplasma as common causes of pneumonia in younger children, if there is a significant family or household member who is within the older age group who is having similar symptoms, younger children certainly can be infected with Mycoplasma. So keep this in mind, particularly if you have a patient who is in the age group where you would normally be treating with amoxicillin, but they aren't really responding as you would anticipate. And since we live and practice in Arizona, I would be remiss not to mention that, remember, a high number of respiratory illnesses in our communities are probably attributable to coccidiomycosis or valley fever. We know that most healthy children experience mild cases of coccidiomycosis, and they'll resolve spontaneously without any antifungal treatment. But in cases where the patient's not improving on what should be effective treatment, you could consider sending coccidioides serologies to assess for a fungal pneumonia. And remember that in those cases of coccidioides infections, most children do great with oral fluconazole. Going back to the original question, the writer asks, when would you prescribe a nebulizer? Well, I have to admit, I don't use nebulizers often in management of pneumonia. However, if it is a patient who has a known history of underlying asthma or has evidence of wheezing with their clinical presentation, then they may benefit from albuterol treatment. And I'm guessing that was the intent of the question, specifically asking about albuterol. Now, if the listener was asking more about antibiotic nebulized therapy, there really is no evidence to support its use in treatment of routine community-acquired pneumonia in children. Just for some context, there have been some clinical scenarios where adjunctive inhaled antibiotic therapy is useful, but that tends to be looked at more in cases of eradication in individuals with damaged airways, such as cystic fibrosis. In particular, my concern is that inflamed airways and dense consolidation in the area of infection doesn't allow inhaled antibiotics to reach the terminal airways in concentration sufficient enough to rely on it for treatment of acute pneumonias. So for the time being, until I see any better data on its use in acute treatment of pneumonia, I really think that we still need to be relying on systemic therapy with either oral or IV administration in pediatric patients. All right, and moving on to question 3. Another listener wrote in, as we approach tick season, for those traveling to states with large tick populations, how can parents prevent Lyme disease? And if a tick bite does occur, what is the recommended protocol? Now, this is a question that's near and dear to my heart. Not only did I grow up camping in northern Wisconsin, but for several years I actually practiced pediatric infectious diseases in north central Wisconsin before coming back down here to Arizona. Now, before I jump right into answering the question, I'd just like to point out that even though the listener asked specifically about Lyme disease, we need to remember that there are lots of other tick-borne illnesses throughout North America that are outside of the maybe Lyme endemic region. So even if someone's not traveling to sort of the upper Midwest or the East Coast and New England, I think it's important to counsel families on avoidance of ticks if they're going to be doing any sort of outdoor activities that may put them at risk for exposure to any sort of tick population in the U.S., because we know that there are lots of other illnesses out there such as Rocky Mountain spotted fever, Babesia, Ehrlichia, Anaplasma, and lots of new emerging viral tick-borne illnesses such as Powassan virus, Bourbon virus, or Heartland virus. And the common theme here is that for all of these illnesses, tick avoidance, tick bite prevention, and then detection of ticks if they're attached is crucial to prevent transmission of these tick-borne infections. So when you're counseling families who are going to be doing lots of outdoor activities this summer, there are a few key points that you want to go through with them. First, if patients and families are traveling to areas where there are heavy endemic tick populations, and particularly those that we know transmit infection, we want to make sure that they know what types of bug repellent they should be using. Now, first thing to say is that this bug repellent should be applied to exposed skin. And in terms of what products are out there on the market, most people recommend that you use something either with DEET or picaridin. Now, there are some other agents out there on the market, but I really recommend to my families that you look for something with one of those two active ingredients. Additionally, because how often you have to apply those products varies depending on both the active ingredient and the concentration of the active ingredient, you want to tell the families to really make sure they're following the application instructions on the individual product that they're using. Additionally, remember that sunscreen should be applied first, and then after drying, repellent should be applied on top. And finally, for those people who are going to be doing lots of heavy activity in endemic areas, they probably also want to think about treating their clothes with a product called permethrin. As with bug sprays, it's important that families follow the instruction closely when using permethrin because it's not supposed to be applied directly to the skin. Now, while these bug repellents are pretty effective at tick avoidance, we all know that nothing in life is perfect, so it's also important that you advise your families that they do a full tick check at the end of every day that they've spent outdoors. And for parents of young children, it's really important that the parent be the one to do this tick check, particularly because they like to burrow in areas that are dark or warm, so they oftentimes hide in the skin folds or along the belt or sock line, and occasionally you'll see individuals who find them embedded in the hairline. So these are particular areas where families should pay attention. Because ticks need to be attached for about 36 hours before they finish a blood meal, at which point they actually disgorge their salivary gland contents, which is how infection spreads. As long as you are doing a tick check at the end of every day thoroughly, in theory, even if there is a tick attached, there's a low risk of transmission, at least for Lyme disease, where this has been studied most extensively. If a tick is identified, then it's important that the family also understand the best means of removing the tick. Now, for those of us who grew up in tick-endemic areas, we all may have heard some kind of funny ways that you can remove ticks, including burning them with a match, covering them with Vaseline or petroleum and waiting for them to willingly remove themselves, or even crushing them between the fingers. Now, none of these methods are recommended, and the best means of removing a tick is actually to use a pair of tweezers, grasp the tick at the head as close to the skin as possible, and then applying gentle upward pressure until the tick is removed, with cleaning the site afterward with soap and water. Then the final thing to say here is that even though the data to support this approach is incomplete, in some parts of the country, individuals recommend that after a tick bite you can offer prophylaxis if the individual is living in an endemic Lyme region. So you can consider post-exposure prophylaxis if the individual is in a high-risk endemic area. The tick is confirmed to be an Ixodes or black-leg deer tick, which is the tick that transmits Lyme disease. The tick has been attached for greater than 36 hours, and you can initiate therapy within 72 hours of tick removal. If you are going to be using post-exposure prophylaxis, the medication that has been looked at is oral doxycycline, which is actually very effective at treatment of Lyme disease. If these criteria aren't met, then post-exposure prophylaxis is not recommended, and rather families and patients should be counseled to just monitor for symptoms that would be consistent with Lyme disease. And now, moving on to our final question. One listener asks, for expecting mothers that have been infected with toxoplasmosis, what treatment plan is most effective for the baby and mother? Now, the first thing to say here is admit that as a pediatric infectious disease physician, I don't often get involved with the management of pregnant people, but I think it's important to review this so that we can understand as pediatricians what is the most effective treatment that protects not just the mother, but also the fetus and infant. Now, I think we all understand the importance of toxoplasma during pregnancy, but just to review quickly, when toxoplasma infection occurs during pregnancy, it carries a high risk of severe outcomes in the developing fetus and the newborn infant. And like other congenital infections, the likelihood of congenital infection increases if the mother acquires infection later in pregnancy, but the effects are more severe if it's acquired early, due to the effects that the infection has on the developing fetus during the critical period of organogenesis. Thankfully, with regard to toxoplasma, incidence has dropped over the last several decades with improved education of pregnant women to avoid exposure to both cat feces, where toxoplasma can be transmitted, and uncooked deli meats or hot dogs that could potentially harbor Toxoplasma oocysts. Diagnosis is considered in pregnant women with flu-like illnesses characterized by fevers, chills, sweats, headaches, myalgias, pharyngitis, hepatosplenomegaly, and or a non-pruritic rash. But most infections are actually asymptomatic or minimally symptomatic in roughly 80% of cases. Diagnosis is based on serologic conversion obtained either due to those maternal symptoms or fetal findings on prenatal ultrasounds demonstrating concerning findings such as intracranial calcifications or ventricular dilatation. And because of the severity of infection and the complexity of treatment, typically those serologic tests are then confirmed by doing an amniocentesis with PCR for toxoplasma at or after 18 weeks. If then toxoplasma is confirmed in a pregnant patient, treatment is offered, but it really depends on the stage of therapy, and that dictates which agents you'll use. So treatment is usually used to reduce the risk of congenital toxoplasma, and it should be started as soon as possible after diagnosis in the pregnant patient. Because infection in healthy adults, including pregnant individuals, is usually a self-limited, non-severe disease, treatment offers no direct benefit to the pregnant patient. As I mentioned previously, which antibiotics you're going to use depends on the gestational age of the infant at diagnosis. If you make the diagnosis in the first trimester, the recommendation is that you're using spiramycin in the mom, whereas if the infection is diagnosed after the first trimester, then the recommendation is you should be using pyrimethamine sulfadiazine. Evidence does support that pyrimethamine sulfadiazine is superior to spiramycin for treatment of toxoplasma, But unfortunately, because it carries teratogenic risks, it's not recommended that you use it in the first trimester when, again, there is a high risk of complications in the fetus during the period of organogenesis. If infection is confirmed at 18 weeks or later by PCR, then most experts recommend that you continue treatment with pyrimethamine sulfadiazine until the infant is delivered. I think the final thing to say here is that because this is a crucial infection to start treatment for as soon as possible, and because these antibiotics that are recommended are not often easily acquired immediately, we know that Bactrim, or trimethoprim sulfamethoxazole, is effective at treating toxoplasma. So most experts recommend that until you can get either of those other agents, either spiramycin or pyrimethamine sulfadiazine, depending on their gestational age, you should start Bactrim until those other medications can be started. Now, I will admit there may be some more nuance to management of toxoplasma in pregnant people, but because it's not my specialty, I'm just going to leave this here and just say again that if there's further follow-up questions people would like to ask, feel free to email in after you listen. And with that, we're finished with another week of ID Talk. Thank you again for listening. Remember, AzAAP members can submit questions for future episodes to id@azaap.org. The AzAAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, visit azaap.org. As always, thank you for these interesting consults, and we'll see you next time on ID Talk.